Welcome to our webinar today. My name is Sarah Montel. I'm a registered dietitian and from Indianapolis, Indiana, and I am here as your moderator. I don't know if any of you had a chance to attend our weekend session. So we have an ASMBS weekend session, and we have chosen today our top 3 presentations, and we would like to give everyone kind of a chance to hear our top speakers and get their questions answered. So really excited to have all of you here today. We're going to let all of our speakers present, and then at the end we will have some time for questions. So save your questions till the end. We'll get through as many as we can. If there's some that we can't get, we can definitely address those through our Facebook page or that sort of thing. If you like our speeches and our speakers today, just to remind you, we always have our annual meeting in June. So this year we're going to be in California. So this is kind of a taste on some of the different presentations that you have and that we will give at these upcoming events. So I have three speakers today. I have Dr. Albaugh first. I have Kathi Ling, and I have Dr. Katie Queen. So they all have great presentations today. I'm going to let Dr. Albaugh start first. I want to tell you a little bit about him. First of all, his presentation is going to be today why we call it metabolic, which I think is kind of a great way to kind of kick off our webinar today. So a little bit about our speaker. He earned his medical degree from Penn State University College. He has completed his residency in general surgery at Vanderbilt and his fellowship at advanced laparoscopic at Cleveland Clinic. He's the assistant professor of metabolic surgery at Pennington Biomedical Research Center in Louisiana State University and an assistant professor of surgery at LSU Health Sciences Center in New Orleans. He is a diplomat of the American Board of Surgery. He has lots of scientific training, earning his PhD in physiology of metabolism and emphasis on control of body weight and diabetes. Great information here. He completed a postdoctorate research fellowship in surgical metabolism and bariatric surgery, supported by the National Institutes of Health. As a physician scientist, his interest includes the investigation of the mechanism of weight loss surgery, identification of patient predictors of successful obesity treatment, and investigation of lifestyle, dietary, and medical treatments for obesity, diabetes, and non-alcoholic fatty liver disease. He is a co-author of more than 50 scientific articles, and including some editorials, book chapters, and reviews. So great bio. We're really excited to have you today, and I'm going to go ahead and let you take it away.
Thanks, Sarah. I think you can see my slides if I shared correctly here. So I gave a brief talk, or I'm going to give a brief talk on kind of what I discussed at the obesity weekend, kind of why do we call it metabolic. And let's see if I can. So here's my disclosures, which I don't think affect anything I'm going to talk about today. The objectives from the original presentation are here. I'm not going to read those, but really it was trying to understand, why do we call these operations metabolic surgery? And it's definitely a big paradigm shift over the last 20 to 30 years. So I'm just going to review some of what I discussed in an abbreviated fashion at the meeting. And I'm glad to hear it was so well received. I didn't know I was one of the top 3. I'm in good company here. So I appreciate the IH group for that. So essentially what my laboratory does is, we basically say, if we could figure out why surgery is so effective, then maybe we could make a widely available treatment. And ideally not have to do surgery on people. Obviously, I'm a surgeon. And people say all the time, so what are you trying to do? Put yourself out of business? Absolutely. That is exactly what we are trying to do. Now, the issue is that, people say, well, how does weight loss surgery work? Or how does bariatric or metabolic surgery work? And, historically, surgeons would say these things like, well, you know what? We make your stomach smaller so you can't eat as much. That's this gastric restrictive component. And then we bypass part of your intestine, which you can't. So we're forcing you not to absorb as many nutrients. This idea of malabsorption. And so you'll hear people talk about these. Hopefully not as much anymore. This idea of restriction and malabsorption, and we know that that's probably maybe even, I don't want to say opposite the response, but those things are probably very, very little in terms of how these operations actually work. And I'd like to show a few things here. This is some data from a great study from Bernadette Grayson, who's at University of Mississippi Medical Center. She's a veterinarian, PhD. Their group showed they took advantage of the fact that pregnancy and lactation are some of the strongest stimuli for food intake in rodents, and they had a rodent model of sleeve gastrectomy, the VSG here in the graph. And we know from a lot of studies back in the 70s and 80s that depending on the strain and the number of pups, when female rats are feeding or lactating and they have pups, you can actually give back pups, and the rodents will increase their food intake because there's more stimulus for milk production. If you take the pups away, their food intake will go down. So it's, you can imagine they increase their caloric intake 3 to 5 times. So it's almost be like a woman, breastfeeding, and if she usually eats 2,000 calories, well, now she's eating 10,000 calories. So it's a huge change. So what they did was they took these female rats, they did sleeves on half of them and shams on the other. And then they looked at the response to lactation, and this is food intake here on the left. And with the idea being, if the sleeve is so restrictive, and if it's really that tight sleeve that a surgeon makes that keeps people from eating, these animals would not be able to eat. Well, what they found was the response to lactation in terms of food intake was just as good as the animals that had a sham or a control operation. And immediately after the pups being weaned, that goes right back down. They open these animals up, they look at the stomachs, they're not all stretched out and all the things that, you'd think, but really if the stimulus is there, the body is going to get the calories in. So it's not, sleeve gastrectomy is not intrinsically restrictive. There's also a lot of data that's been presented in the past by great scientists, Blondine Laferrere and Carel Leroux's group, showing, when you intentionally look for malabsorptive evidence, specifically after a gastric bypass, it's really hard to find that. And so, this restriction and malabsorption probably are, like I said, pretty far away from actually being, drivers of the weight loss. And we know that the weight loss is not because of the restriction and malabsorption. So the other focus of this session, which was kind of more of a doom and gloom session, kind of bad things that can happen. And so I presented this data to the group. And I said, what are some of the common bad things that can happen after metabolic surgery? And it was mostly IH folks, but everybody knows, people struggle with getting their fluids in. They struggle with nausea. And so, we looked at this list here, and these are all very common things. And most of these can be very minor and aren't that big of a deal. But they're issues for our surgical patients in the first few weeks, especially. Very common to have some nausea and vomiting, even some dehydration. We know that some people need to get, readmitted back to the hospital. Reflux can be an issue for some folks. We have some people who struggle with constipation, while we have other people who struggle with diarrhea, and we kind of rationalize all these things, abdominal pain and gallstones and vitamin deficiencies. We say, well, these people had surgery and we're doing all this stuff to them, and we've really, they're having a big inflammatory response. And so, these must all just be related to the operation. So then I rephrased the question and I said, okay, well, now let's talk about, what are the common bad things, so to speak, that can happen after starting GLP-1 meds? Very similarly. And so went around the room and we said, yeah, you know what? A lot of these folks, they have issues with nausea, vomiting, dehydration. In fact, some people even have reflux, and some people struggle with constipation. These are listed on, Lilly and Novo Nordisk's, websites. Some people struggle with diarrhea, very common GI side effects. And as you can see here, when you look at the list, we're seeing that, both of these very highly effective weight loss treatments have similar adverse events. And so when it was, before the GLP-1 agonist came along and surgeons would talk about how surgery works, we didn't really have a lot of really good mechanistic data. But now that we have these GLP-1 medications, these are really, this is like what I told the audience was, this is really like the best mouse study you could ever do. Because we take something that's really complex that has a big effect, and now we are able essentially to mimic a lot of that effect, maybe not all of it, but a lot of that effect just by injecting one particular gut peptide agonist with the GLP-1 drugs, a semaglutide. So when you think about, what are the mechanisms of the metabolic effects of these bariatric operations, highlighted in red here, this altered secretion of gastrointestinal hormones is probably driving a very large percentage of that response, although there's a number of other things that are probably also involved. We know this group of peptides here, or hormones on the left. We know that GLP-1, GIP, glucagon, even those first three when you look at the newer agonists that are being developed, that triple G paper that just came out a few months ago in the New England Journal is specifically looking at a molecule that mimics GLP-1, GIP, and glucagon. And so we know that a number of these things are changed after weight loss surgery. We know that these hormones have all sorts of effects in the body and probably in the central nervous system. And they probably have a lot to do with the response after bariatric surgery. We know clinically that, people say, these types of things after surgery, I don't get hungry. I don't really have a craving for certain things. I like certain foods. We know that, in the long term, all of these things on the left really translate into these responses or these long-term effects on the right, decreased caloric intake, decreased intake of energy-dense foods, and then increased intake of healthy foods. And there are some animal studies even to show that animals will shift what they eat from lower fat to higher protein after these operations. So why is bariatric surgery so effective? It probably has to do with these hormones. And even though we're operating in the abdomen, we're probably actually modifying the brain a heck of a lot more than we probably ever would have thought. So my laboratory studies the gut-brain axis, and I'll just finish with this. The gut-brain axis is a very complex physiologic phenomenon where we've got not only kind of hardwired neural connections between the intestines and the brain and other nerves like the vagus nerve and the spinal cord, but also these endocrine mediators. And so we are really targeting number 3 here with these newer medications, the GLP-1 drugs and the triple G and the tirzepatides of the world. And so really, is it possible to measure, this signaling, in people? And it definitely is. And so we do this at Pennington. We've got some functional MRI studies that we've got up and going, and I'm not going to show any data, but I always tell folks that you can, if you take a person who has lost weight with diet and exercise, and you put them in an fMRI, and you show them a picture of a donut, the visual cortex lights up because they see the donut. If you tell them, if someone says donut, the auditory cortex in the brain lights up, as well as all of the other areas of the brain that are also known to be excited, in people who struggle with addiction and alcoholism and things like that. So the interesting thing is when you take somebody who's had weight loss surgery and you do that same experimental paradigm, someone who has lost just as much weight as somebody who's really starved it off themselves with diet and extreme exercise, you don't see that brain activity change. And in fact, we know that, actually, let's go to the last slide here. We know all these sorts of things affect brain activity. And after bariatric surgery, when you look at functional MRI, this is a kind of a summary slide from a study a couple of years ago by a group that was published in Diabetes Care. If you quantify how active certain regions are the brain before and after weight loss surgery, and you compare those to diet and exercise weight loss, we know that, again, the black bars here would be the folks who lost weight with a very low calorie diet. And there's a much greater increase in the reward pathways and executive control. And the response in somebody who's had bariatric surgery is almost the opposite. So it's almost like if you put 2 and 2 together, what we're seeing clinically with what we see with brain imaging, it's almost like we are giving people almost a more of a willpower, so to speak, even though it's probably not as much that, but we are altering brain activity. We are altering, long-term circuits that are probably having a big effect on health overall and body weight regulation. So these known gut hormones that we've thought were important for a long time, now that we've got the medications, it's clear that those are probably a significant contributor. But really targeting that gut-brain axis is a very powerful regulator of body weight regulation. So I will go ahead and stop here. This is my acknowledgments with a lot of the team members here and our funders. But appreciate the opportunity to talk about this again. Thanks.
Mute. Okay, that was a fantastic presentation. Thank you so much. We really appreciate that. I have a lot of questions. I think a lot of you do. We'll save those to the end. I'd like to introduce our next speaker. We have Kathi Ling. She is a director of physical therapy, and she practices at the University of Oklahoma. She had her bachelor's of Science of Physical Therapy in Washington and went to medical school in Montana. So her special interests are bariatric surgery, rehab exercise, and lifestyle changes. Her topic is a good one. I think it's one we don't hear often, and it's how to build an exercise program and the role of physical therapy in your practice. So thank you so much for speaking to us today. I'll let you go ahead and start.
All right, well, thank you. Hit share. Actually, I don't have an MD. I'm a doctor of physical therapy. I went back and transferred my degree. I upgraded it from a bachelor's to a doctorate. And I've been a physical therapist about 37, 38 years now. See if I can get that going. Working in all kinds of different areas of therapy. I'm also an adjunct professor at University of Oklahoma Physical Therapy School. When I started this, because like she said, there's not a lot of it out there. Some of you guys have relationships with exercise physiologists, but not a lot of physical therapists working in this field specifically. So I turned to the research and didn't find a lot in what to do with patients post-op for physical therapy and for exercise and activity. The studies that I found were talking about as much as 20 to 30% of the weight loss after surgery was from fat-free mass. So I started looking for ways to maximize skeletal muscle and even prevention of osteoporosis following the bariatric surgery. The primary research study that I found that addressed some of the things that I was looking at was one out of Tehran in 2017. They took 60 patients with a BMI of higher than 35. They were randomly assigned to control group, an aerobic exercise group, and an aerobic plus a little bit of strength training. They were assessed pre-op, and at 12 weeks post-op, they were both from sleeves and from Roux-en-Y surgery. Proteins and calories were similar and logged, and they had a very specific set of tests that they did. The procedure in the first 4 weeks post-op, they were walking 150 minutes a week for the aerobic group and the aerobics with exercise per ACSM guidelines. And then they were increasing their speed as tolerated after surgery. The 5 to 12 week group, they were increased to 200 minutes a week at a moderate intensity using a 12 to 14 on a Borg scale. The strength training group was also given therapy bands. Women were given green, men were given blue, which based on my time with my patients, unless they're bedbound patients, is actually pretty light on the resistance. Most of my patients are really quite strong. So green and blue is a fairly light workout for a lot of them. And they were exercising 3 times a week for 20 to 30 minutes with things focused on shoulders and hips for strengthening. Some interesting results were coming up out of this. The control group lost about 45 pounds in the first 3 months. The aerobic and the aerobic with strength training both lost pretty close to 55 pounds during that same time period. The percentages of fat loss to skeletal muscle mass loss were what I was looking at mainly, and just that the aerobic group or the group with the strength training was losing a little bit less in the area of skeletal muscle, even in the first 3 months. And so it's like, well, if they're working out that light in that first 3 months and protecting a little bit of skeletal muscle there, what happens if we are giving them a higher exercise program and encouraging more weights and exercising in a way that would increase muscle mass that would be normally used to increase muscle mass. I'm afraid those studies don't exist. I'm hoping to get there, but this was what I designed my program around. So our goals are to evaluate for comorbidities and any kind of activities or anything that might cause inhibition of being able to complete an exercise program. And then we develop an exercise program for all of our patients on including something cardiopulmonary, some strengthening, some flexibility, and some balance activities. My program starts with a Zoom class where I give some general exercise education sometime in the first month or two in the program. Then we have a one-on-one evaluation preoperatively where we look at all those comorbidities, give more education, and give a personalized program. And then we work with follow-up visits at 1 month, 3 months, and 12 months post-op to refocus their program at those times. Evaluate all these areas here. I'm not going to go into them. Endurance. I do a 6-minute walk test with each of my patients. I do not use the treadmill. I want to see what their gait pattern looks like. I want to see what speed they choose, whether they're walking with good foot support, whether they need different shoes or orthotics, all kinds of things. I want to know what their knees are doing, hips, back, so on. Exercise prescription. My number one focus for pre-op is the cardiorespiratory. Part of that is enhancing their weight loss, but most of it is talking about building up their cardio endurance and their respiratory endurance, preparing for surgery itself and for immediately after and the recovery after surgery. I want to make sure that their heart and lungs respond well to stress placed on them. You know, somebody who gets short of breath emptying a dishwasher, might have a little more trouble during surgery, after surgery, trying to recover. So we're really focused on trying to get their cardiorespiratory strength up and so on. Choosing all kinds of different activities. I usually sit and brainstorm with them about what they like to do, what their lifestyle is like. One of the things that I do use that's a little bit different than other people, patients who either have so much weight that they cannot do a sufficient speed or length of time, or they're having enough pain, like back pain, knee pain. People who are waiting for total knee replacements would have a hard time walking for 30 minutes. So I will often use these little leg bikes to have them pick up one of these. They're fairly inexpensive. A lot of people have family members with them in the garage or under a coffee table, and stick it on a dining room table, and they can do their cardio pedaling, and they can usually last a lot longer, and use that as a means to an end to help out with building their cardio endurance. I take a look at flexibility. I want to know what their hamstrings are like, their hip flexors, because that has a lot to do with back pain, knee pain. We'll take a look at shoulders, upper back, make sure everything is moving well so they're not getting hurt while they're exercising, and to get some of their mobility back. Resistance training exercises. Get them started initially in my session, my one-on-one session with them. I give them a therapy band, teach them a few exercises. I give them a handout that can be used for dumbbells or bands or the machines at the gym, any of the above. They don't have to specifically do my exercises, but they're basically, this is a general thing to make sure we look at arms and legs and core, both range of motion and strengthening. By 3 months post-op, I want to progress to a heavier weight. I want them to fatigue between 10 and 15 reps, and do 2 or 3 sets of those. And that's what they can work up to. Those are the goals. And that will help prevent some of that muscle mass loss and, lower their risk of osteoporosis. I definitely focus a lot on keys on engagement. I want them to, first of all, their exercise program is kind of cool. I use a program that can be delivered to them by email, or even better, by a phone app. So even when they leave my office, they have it downloaded, and it's right there on their phone. They can take it to the gym. They can do it in their car while they wait for kids. They can do exercises wherever, and a lot of those exercises they can take with them. Want to design a program that works with their needs. What are you doing? How many kids do you have? What kind of work do you do? How many hours do you work? We talk a lot about that. I hand everybody a 10-pound weight. I want them to know what 10 pounds feels like. If they come in and say, I've already lost 20 pounds, I say, hey, you've lost 2 of these. Can you imagine carrying 2 of these around all day today? How much pain would you be in? How much harder would it be to do activity? And that usually a little light bulb, their eyes light up a little bit and they go, wow, I didn't know that that's what 10 pounds felt like. I know what it feels like in my clothes. I know what it looks like in the mirror. I didn't realize that that's what it felt like for life. And then we talk about the study a little bit, and we start focusing on one thing at a time and kind of building up from there. Engagement in the community. A lot of my patients don't like to go to gyms, either because they feel they're insecure with how they look, or people coming up to them and making comments, or they have never been in a gym and don't know what to do when they get there. And that's very intimidating. So consider the use of establishing a rapport with a local gym or exercise physiologist, and talking to them, maybe a special pricing deal for your patients, a special program that they can go in and learn what to do. Here at OU, we have the healthcare center gym has a deal for our patients that they charge $60 for use of the gym for 2 months. That includes school. And they meet with a trainer once a week for 8 weeks. And our trainers absolutely love our patients because our patients are motivated. They want to lose the weight, they want to get strong, they want to get functional. And these guys are really good at even working with medical problems. So I write on the back of the prescription, back pain or knee pain or things like that, rheumatoid arthritis, because we address that differently. And they can use that gym, and then they can take that back with them to their own gym, or they can join that gym, whatever they want. How to refer your patients to a physical therapist. Most insurances will not cover therapy services for obesity, for weight loss, for bariatrics. However, they will cover therapy services for things like pain, musculoskeletal problems, neurological conditions that affect their functional activity. And believe it or not, patients who have an increased respiratory or cardiac response to a normal functional activity. So if a patient is emptying their dishwasher and their heart rate goes up to 140 to empty the dishwasher, that's considered an abnormal response to a normal functional activity. Okay. And if you are documenting that in your notes, you can refer them to physical therapy to address that problem. So dressing, bathing, you can go to physical therapy, you can go to occupational therapy. Work with your physical therapist. If you get a relationship with a physical therapist, work with them on the wording for your referrals, and make sure that they understand that if you refer this person in for knee pain, that you don't want them to just address knee pain, but you also want them to find a means of cardio exercise that they can do with that knee pain. So they need to find an alternative source of regular exercise, that they are still looking to be doing strengthening and cardio and flexibility work for their general body, because that's what you need them to do to meet your goals in bariatrics as well. And you should be able to establish that kind of relationship, and they can include that in their goals. Okay. And then we'll take questions at the end. I think I made it.
That was a great presentation. Thank you. I was over here taking notes for my very own practice, so I appreciate all of that information. I think we're going to go ahead and start our last speaker today. I have Dr. Kathi Queen, who's going to talk to us a little bit today about pediatrics and adolescents. So let me tell you a little bit about Dr. Queen. She's a pediatrician who's passionate about preventing chronic disease and obesity in children by promoting healthy lifestyles. I think this was fun. She became interested in nutrition and physical activity when she used to do step aerobics with her mom at the local gym. I have that same memory. She completed her degree in liberal arts at University of Texas and her AFAA training to teach group exercise. She was president of Nutrition and Wellness Association. Then she went on to complete her medical degree at LSU School of Medicine in New Orleans. And then she did 2 months in elective months, and during her 4th year at UCSF and Duke, learning from experts in childhood obesity. She had a residency in LSU Pediatrics in New Orleans, and she received the American Academy of Pediatrics Catch Grant to design and implement an intensive healthy lifestyle program for kids and their families. She's an active member of the American Academy of Pediatrics. She's working on creating a section for the state chapter. She believes in practicing what she preaches. She has a healthy mind and body, enjoys daily meditation, healthy cooking. Even when she's home with her 3 kids, ages 1, 3, and 5, you are busy. They're laying on top of her while she's doing yoga and push-ups. So definitely practicing what she preaches. She dreams giving her own children water instead of sugar, sweetened beverages and snacks, not only at home, but at school. So she's going to have people put down their electronics and they are going to move rather than sit. And I can't wait for you to change the world. So thank you so much. I'm really looking forward to your presentation.
Thank you, Sarah. It's funny because my kids are actually now 5, 7, and 9. So I must have copied and pasted that introduction without changing the ages. And I think I need to update that. But yes, and I still do yoga and they still climb on top of me. So all right. So let's share my screen here. Let's see here. Okay. And we're gonna start. Okay. You see that okay? Yep. Okay. So my topic at the October meeting was, I was asked actually to speak on specifically anti-obesity medications for pediatric and adolescent obesity. And so this is my 3 kids. You can see they're a little older than the 1 years old. My youngest now is 5. And I also am board certified in obesity medicine. That was my COVID project. As I said, well, might as well go ahead and get my board certification after COVID. And I've been doing weight management for the past 2 years in the Children's Hospital. I do have 3 conflicts of interest. I'm on the Speakers Bureau and I've done some advisory board work. And none of that is going to really impact this talk. And just gratitude to the ASMBS. This is actually, my disclosure is also, I'm actually not a member of the ASMBS, but I intend to become a member because I'm working with our bariatric surgeons to develop an adolescent bariatric program. And so this has been my first experience with ASMBS, and I'm excited to learn from other providers. For example, from Dr. Ling, I learned some things today. So thank you guys. And this is the name of our clinic. So we're located in Baton Rouge, Louisiana. I'm born and raised in Louisiana. And this is just the ribbon cutting for our 1-year anniversary. We've now reached our 2-year anniversary that we've been open. And we have a multidisciplinary clinic with dietitians. We have a behavior coach, social worker. I would love to get a physical therapist one day. And, you know, we have a wait list of 1,000 patients. And so we've got a lot of room to grow. And the objectives today, we're going to jump right in just because for the sake of time. So the treatment of pediatric obesity is very similar to the treatment of adult obesity in that the foundation of the treatment is behavior and lifestyle counseling, and visits related to nutrition, visits related to coaching, exercise, physiology, recommendations for that kind of thing. So I want to make sure that you understand that I am going to focus on pharmacotherapy today, but that's always in the context of working with the family on behavior goals and behavior changes. And so that's very, very important to understand. The media, I think, has sort of forgotten that piece of things and made it a little bit, I guess, some pushback on pediatricians now prescribing obesity medications, but it's always recommended in the context of counseling the families. And then, of course, bariatric surgery, Dr. Albaugh, that's his kind of specialty. So just for the sake of time, I'm not going to go into all the details, but these are, and I'm happy to share my slides. I saw the comment in the section. I'm happy to share my slides. These are the BMI cutoffs. So when we talk about pharmacotherapy, any patient, this is very important, any patient with obesity, which is defined by a BMI of 30 in adults or adolescents, or in pediatrics, we use percentages. So if they are the 95th percentile or higher for BMI, we use growth charts that show us that. Or if they have a BMI of 27 or higher with a comorbidity, then they are a candidate for pharmacotherapy. And we know that pharmacotherapy is kind of a lot more bang for your buck. We know that behavior and lifestyle treatment, you can see on the right-hand side, can give you some really good lifestyle changes. The patients feel good, they can move more. Often they can improve their A1C and their blood pressure. But if we really want to reverse comorbidities such as diabetes, true prediabetes or hypertension, fatty liver disease, sleep apnea, if we really want to help our adolescents, in my case, we are going to need to consider pharmacotherapy. And the average pharmacotherapy or medication is going to give you 5 to 15% weight loss, versus behavior and lifestyle treatment may at best only give you 3 to 5% weight loss. Except if you're on the Biggest Loser show, that might have been more, but we know from the studies that that was not sustainable. And so when I talk about this, we're talking about adding this on to the behavior and lifestyle treatment. All right, so this is something that is also a key take-home point, the key action statement from the 2023 American Academy of Pediatrics Childhood Obesity Guidelines. So this is brand new this year. It was the first time they had given out guidelines in 10 years. If you haven't seen them, you should go check them out. It's a really big document, but there's a lot of really cool tools on the website. And this is the key thing, is that they said that pediatricians and primary healthcare providers should offer adolescents 12 years and older with obesity, which we just discussed, 95th percentile or higher, weight loss pharmacotherapy, according to indications, risk, and benefits, as an adjunct to health, behavior, and lifestyle treatment. So in other words, it's no longer that a child walks in the door or an adolescent walks in the door and they have obesity and we say, hey, I'm a little concerned, your child's growing a little fast, but it's okay. They're going to probably grow into it and they're probably just going to get taller, and we'll just wait a little bit and we'll just, we'll check it in a couple months or maybe just come back next year. That's what we used to do. And actually, honestly, that's what a lot of pediatricians still do. But now we have evidence-based guidelines that say we should be offering these medications, and it's not the specialists that need to be offering it. It's the primary care providers. And then there's a consensus recommendation for those kids under 12, that those kids under 12 may be offered medications. And in that case, right now, that would be an off-label indication, which I'm not going to go into today, off-label medications. I do that, but for this talk, I want to go over the FDA-approved medications. So what are the FDA-approved anti-obesity pediatric medications? Well, it's the same ones that adults use. We just have less options. So right now, the FDA has approved these 5 medications. It's actually only 4 medications because of the combination. So orlistat, been around a long time. I have never prescribed it. I don't know any colleague that has prescribed it other than maybe some adult colleagues. And kids, you don't really want to cause them to have a bunch of diarrhea, and especially when they're in school. So we don't really use that one. Okay, liraglutide was the next one that was approved, and that is a daily injection. Actually not a big deal for a lot of adolescents, and the average cost is about $1,000 to $1,300. And then there's the problem that it's only approved 12 and up. So those kids under 12, we can't usually get that approved. The next medication that's approved is phentermine topiramate, with a brand name would be Qsymia, which I'll go over the brands a little bit later just so you have a reference. And that's for 12 years and up, and that's our only oral FDA-approved medication. And that one we can get for anywhere from about $80 to $100 a month. So a lot more economical than the liraglutide. And then if you take out the topiramate, because there are a lot of side effects from topiramate, you've got phentermine alone. But here's what's really interesting is that for some reason, the FDA has approved phentermine alone 17 and up. They have not given it the indication down to age 12, even though they gave it the indication as a combination medication. So it's a little bit of gray zone. Can I prescribe phentermine alone for a 12-year-old? That's kind of up to your discretion, I guess. I personally do, but I've come to terms that I'm okay to defend myself for that. And then there's semaglutide, which is my favorite actually, because it's a weekly injection, and in the studies, it's the most effective that we have for adolescents. And again, that one is very expensive, probably the most expensive, an average of $1,500 if you're going to pay cash. So I kind of made a table to organize myself. And again, I'm happy to share this. And this table just goes over what are the different mechanisms, the average percentage weight loss in the studies, what are the side effects, what are the kind of contraindications versus relative contraindications. And just to note, the red words are specifically for topiramate, just so I could show you what the side effects were from topiramate versus phentermine. And also to note that semaglutide and liraglutide really mimic each other in their mechanism, in their side effects. And so I'm going to go a little slower over semaglutide, and that way we can speed through liraglutide. And the other thing I want you to note is that semaglutide is the most effective in the studies. And I put here 12 to 15%. Actually, this is an old slide. It's actually an average of 16% in the adolescent studies. The other two were, let's just say, an average of 8%. So the way you can think of it is the most effective one is semaglutide. That's the weekly, and that's about 16%. The other two are about 8% weight loss. So about, in the studies, half as effective as the semaglutide. So if I have a patient who's interested in medication, I'm going to try to get the semaglutide covered just because of what the studies have shown. However, I have a lot of patients who can't pay for the semaglutide, don't have coverage, get on either the phentermine, topiramate, or the liraglutide, and I've seen them lose 15, 20% of their weight. And so remember, these are just in the studies, and this doesn't mean that this is destined to be their weight loss. I also created an algorithm that is really meant for primary care providers who are just kind of getting started with prescribing medications. And again, I think this is actually my outdated one, because even since I gave this talk, I've updated it again, but I'm happy to share it. And it kind of walks you through how do you prescribe these medications. So let's kind of really get into what this looks like in the real world. So these are real patient stories from my weight management clinic. And this is for semaglutide. So this was a 16-year-old female. Remember, this is the weekly injectable. And she came in, she had a BMI of 53.9, which was above the 99.99 percentile. So remember, I said it had to be above the 95th percentile. So she definitely met the criteria. So we know from the guidelines that we should offer medication right as she walks in the door, along with behavior and nutrition counseling. So she had multiple comorbidities, as do most patients when they have a BMI this high. And then this was her growth chart. And this is just a little information about the actual medication. And you can see that, and this is, I'm going to just go over this briefly. If you have specific questions, we can go into it. Semaglutide is FDA approved, but it's under two different indications. The indication for obesity, the brand name is Wegovy. The indication for diabetes, the brand name is Ozempic. And just really interesting is that the FDA has only approved Ozempic currently 18 and up, whereas Wegovy is approved 12 and up. So there's a little discrepancy there, and it's interesting, you know, how the timelines have kind of been off of each other. But this is the dosing, and you can see the dosings are similar, but a little different when you get to the max dose. Also to note that Wegovy pen is a throwaway pen, and the Ozempic pen is a dial-up pen. It's another difference. So remember, I mentioned about 16% BMI reduction, and you can see that this was the STEP Teens trial, and you can see that on the study. And remember, we're not just talking about getting the patient weight loss just to get them weight loss. We're talking about reducing their comorbidities, such as their blood pressure, their A1C, and their cholesterol. So who is this good for? These are really good for patients with prediabetes and diabetes, obviously, because it helps with insulin resistance. It's approved for diabetes. It's very good for people who have a very strong hunger and poor satiety because of the way it works on the GLP-1 receptor. So these are good for my hungry gut patients, and also good for my hungry brain patients. If you've heard of the phenotype idea, that's where I got that term from. And it's also good for fatty liver disease. There's some studies that have shown that. You do not want to give it for anybody with personal or family history of medullary thyroid cancer, although I've never had a patient with that, and we can't use these for pregnancy, which hopefully an adolescent's not going to have. And just be cautious with patients with pancreatitis, gallbladder, or insulin. For the sake of time, I can't go into all the details because I don't have enough time for this talk, but this is all going to be in the slides. And I would say the most common side effect that people complain about is nausea, and you probably have heard of this. I see these patients monthly. I monitor them, and there was some possible suicidal ideation in the studies, as with I would venture to say almost every adolescent drug trial probably has some increased suicidal ideation because adolescents have a high risk for that. But personally, I have not seen that in my population, and I've got hundreds of adolescents on these medications. And so that patient, I apologize. I thought I had a slide that showed her weight loss. She did do really well on the semaglutide. And so let's jump into just an idea of what that would look like with liraglutide. So the same kind of idea, but with a daily injectable. So this is a patient who was 16. She had a BMI of 41, so not as high as the other one. She had similar comorbidities. BMI was also percentile very high. Here's her growth chart. And then you can see I started her on liraglutide. She came to me on metformin, so I just added the liraglutide. I offered her the medication. She said, yes, please give it to me. We worked on lifestyle changes. Our nutritionist would meet with her. We actually changed her psychiatric medication. She was on an antipsychotic for severe depression and schizoaffective disorder. So that had to play into her treatment. And then, of course, our social worker started to work with her. The liraglutide, just like we talked about with the semaglutide, has 2 different FDA indications. So you've got for obesity, it's called Saxenda. For diabetes, it's called Victoza. And again, we've got 2 different ages it's approved for. So Saxenda is 12 and up, whereas for diabetes, they went lower. They went to 10 and up. So I kind of use this sometimes to get my 10 to 12-year-olds on a medication. I'll sometimes use the fact that they've covered it for diabetes in this population. And then just notice there's a lot higher dosing for liraglutide on the obesity side versus on the diabetes side. An average is about 5 to 8% weight loss. So 5% was on the lower doses, up to 8% in some studies. And again, this really did affect comorbidities. And same exact slides as the semaglutide. So great for patients with insulin resistance, great for hungry brain, hungry gut. Be careful about the medullary thyroid carcinoma. And you have to really counsel them on making sure they don't skip too many meals. Our adolescents love to skip breakfast and sometimes lunch because they don't like the school lunch. So we have to really counsel on that protein intake. And like the physical therapist mentioned, is making sure they get their resistance training in so they don't lose muscle mass. So this is the patient. She lost a lot of weight on the liraglutide. I would say more than the 8%. And she did have a little bit of rebound. She actually texted me yesterday and she said, I'm out of my medications. And so as you guys know, coverage is difficult sometimes. And sometimes you have to kind of get on and off medications depending on coverage and availability. Her A1C came back to normal and she's very happy with her success. So the last one, and we're going to probably have to end after this case. I do have more slides, but I want to leave time for questions. So this is the 3rd medication that I use the most often. It's that combination phentermine topiramate. And remember, this is the only oral medication that we have. So this is a 15-year-old female. She came in to see me. Her BMI was 36.6. So remember, we should be offering medication along with nutrition and behavior counseling. And we offered this to her. She also had a lot of anxiety. And at her peak, you can see her BMI. We put her on this medication and she did do really well. She came down a little bit. And unfortunately, I don't have a longer time frame because I've had patients on this the least amount because it was the most recently FDA approved. So I'm hoping maybe if I were to give this talk in a year, I can show a better trajectory. And so phentermine topiramate, I wanted to split it up to show you guys that you actually can get a patient on this by prescribing the phentermine and the topiramate separately. And the actual brand, when it's together, is called Qsymia. It has a long-acting topiramate, whereas the short-acting version would be if you separated it. And so just as if someone is interested in prescribing this table shows you how you could do it and separate it, because most insurance companies will cover topiramate, but they won't cover the Qsymia. Interesting. And the phentermine is not that expensive if you prescribe that separately. So again, For the sake of time, I won't go through all the details, but these are really good for my hungry brain craving kind of adolescents who have a lot of brain cravings because of how topiramate works on the brain. If you think about it, it's used for seizures, it's used for migraines, so it calms down the pathways in the brain. So that's why it's really good for those patients that have a very high craving. And phentermine as well works on the brain, but also phentermine is great for these slow burners, these patients who are just very sedentary, barely do any physical activity, lots of screen time. And if you get them on the phentermine, it's the only anti-obesity medication that I have that can increase their metabolism by the medication alone. Average BMI was about 10%, but again, I told you 8% on average, and I need to update these slides. I'll send you guys the revised slides. And so mechanism of action I mentioned. Things to discuss. So this medicine's a little messier than the other two in that there's more potential side effects. So you have to be careful about any patient who has severe, moderate to severe anxiety, depression, and you have to be careful about patients who have kidney disease. Those are the top two that you have to make sure of. And then of course, it's a controlled substance. The phentermine, it is not fen-phen. It is not addictive. There's no withdrawal potential. This has been around since the 70s. And tell people it's 2 classes below Adderall. And so many adolescents we know are on stimulants. So I try to make it in proportion. You know, it's much less of a strong stimulant than Adderall and Vyvanse and things like that. So for the sake of time, I'm going to stop there. Unfortunately, let me just go to my last slide. I wish I had more time to go through this. Phentermine is alone was average of 4%. Yes, you can prescribe more than one medication. How long will they have to be on it? It depends. It depends on how well they work on their lifestyle change. And what if it's not covered? This is a medical necessity form that I'm happy to share with you guys. And so that's it. I apologize for going quickly, but I wanted to make sure I leave 5 minutes at least for questions. And I'm happy if you guys have questions, email me. Always happy to share my information and collaborate with people. Thank you.
Thank you so much, everyone. This is Cindy. I'm really sorry, and I want to really thank Sarah for jumping in for me there. Technical difficulties are so much fun. Thanks everyone for coming. I really appreciate it. Do anyone have questions? Oh, let me look in the chat here. Gonna be a quiet group. If you do have questions after this, feel free to contact us. We will talk to the speakers and get answers for people. How do we get all the slides? Andronique, are you on? Can we post them?
Presenters can send them to me, and then we will figure out how to get them distributed.
For Kathi, are there any office assessments that we can use to assess muscle mass loss? You think you missed that? I think that one went up too fast, Cindy.
I think in the study they were assessing it with in electrical impedance. Sorry, word finding. And so if you have electrical impedance measurers, you can, tools, you can do that. I know at the conference, Seika was really excited about sharing theirs. And those are all ways of doing that. That's the easiest way. Otherwise, it's all underwater stuff. And
Dr. Ling, do you ever use the what do you call it? The arm body
calipers? My surgeon here wanted me to start doing calipers when I came, and I did a bunch of reading and research. And the problem is that with the amount of weight that people are losing and trying to measure, get a good pinch or whatever, it really isn't sufficient. It's inaccurate because you can't get a hold of, how do you manipulate this tissue to get a caliper measurement? So it would be pretty tough. And especially as people start to lose weight, and then there's a lot of loose skin, and how much of that is there, and how much of that is being determined to be adipose tissue versus loose skin. It's pretty tough to do. And that'll measure your body fat. It won't measure your skeletal muscle. I have a question for you guys, and Dr. Albaugh, both of you actually, for post-surgery, patients are seeing quite a bit of improvement in their PCOS symptoms. Do they get any resolution of PCOS control with the medication weight loss?
Yeah, I'll defer to Katie on that. I know, symptoms get better, but I don't know if there's any objective evidence in hormones. But yeah, Katie, what are your thoughts on that?
1000%, yes. I mean, I'm sure there's studies that back that up, but yes. And the most exciting thing is when a patient comes in and says, "I got my period for the first time in a year."
Exactly.
Like the patient I showed the pictures of with Down syndrome, she had not had her period for over 2 years, and after I got her on multiple medications, we worked on nutrition, behavior counseling. She does not want surgery, even though she qualifies. And she has her period now for the first time ever, which the mom was super excited about. So yes, the PCOS symptoms and the hormones are very much intricately in tune with the insulin resistance improvement. And that would be interesting, Dr. Albaugh, is whether there's studies that show after the surgery, regardless of medication, whether the hormones and the PCOS symptoms improve. I'm sure they've studied that.
Clinically, yeah, I have several patients that have come in and told me that they are now having their periods again. I'm sorry, Dr. Albaugh, I'll cut you off.
I was gonna say, yeah, no, thanks, Kathy. Yeah, Katie, you're right. I mean, so I don't know how much it's published on, but I know that, the fertility specialists in our area actually send us patients specifically because the fertility is very much associated with PCOS and hormonal dysfunction and stuff. So we know that women and men, fertility goes up. We don't worry about as much about it in men as women, obviously, for obvious reasons of not wanting a little baby to be developing when somebody's dropping 100 pounds over the course of a year. But clearly there are improvements in fertility and probably, other markers. So it all kind of, I think, goes hand in hand. And as the medications become more, more widely used, I think it'll probably really stimulate a lot of studies and kind of these other things that we've kind of seen anecdotally, but there really hasn't been much paid attention to it because it was only surgery that ever really got you there. And there's a lot of barriers to doing research in people who have had surgery and with the design of studies. But the medications, I think, will really kind of break that field wide open. But it's a very exciting time to kind of be in the obesity and kind of diabetes fields for sure.
And does it need to be the GLPs or can it be the others? The ones you were talking about, Katie, those are helping there.
Yes, just the weight loss seems to be what the connection is, and their improvement in insulin resistance, because insulin resistance reduces estrogen. And so it sort of puts you into a state of almost early menopause. And so when the insulin resistance improves, the estrogen levels improve, and that's why the periods come back.
Okay.
These are wonderful presentations. Thank you all so much for today. I did, if you are interested in the slides today, if you don't mind to put your email into our chat box, and we can make sure that we get those, get all of those to you.
If you have specific questions we didn't answer either, and you want to put them in with your email, we'll do our best to try to get them back to people. Unfortunately, as you can tell, this is a lot of information that we share at our conferences. And we've asked these lovely speakers to cut this down to a really small amount from what they did. So you can imagine how much more education and information our conferences really do offer us. So I really do want to thank everyone for taking the time out today to come and join us. I want to especially thank the speakers for giving us their time and expertise. Sarah for jumping in for me when my computer decided Zoom would not open. Please remember we are in membership renewal phase. So if you are not a member of ASMBS, please join. And then if you are a member, renewal is now open. Our conference for the next one is going to be our annual conference. It's on June 9th and through the 13th in sunny San Diego. So put that on your calendar because it is a distance for some of us on the East Coast. So you want to definitely mark that up. I'm sure it's going to be another great networking and education episode for all of us. So.
Thank you all and have a great afternoon, and we look forward to seeing you all soon.